So non-protein nitrogens traditionally monitor renal function. Again, kidney for analysis. Okay. So you have your urea, creatinine, uric acid, and ammonia are the ones we're going to talk about. Amino acids again are, remember, the building parts of protein. Those basically what we're going to talk about. So the renal function test. So in other words, a renal panel. So if the doctor wants to assess your renal function by doing a renal panel, he's going to do a BUN, and lab techs call them BUNs, nurses call them buns. So blood urea nitrogen, or you can have urine urea nitrogen, depending upon where you're measuring it, either in the blood or the urine. And then creatinine, and then again urine protein, and then microalbumin, which we talked a little bit about with the diabetes lecture too. So pretty much about half of your non-protein nitrogen substances is urea, okay? It's the main excretory product of protein metabolism, okay? Synthesized in the liver from your CO2, okay, and ammonia, coming from the breakdown of your amino acids in the Krebs cycle. So we have to get rid of that ammonia, because if we don't get rid of that ammonia, it's going to be neurotoxic. It's going to cause problems with your brain, okay? So conversion of ammonia to urea, again, prevents the ammonia toxicity. So it goes from your liver to your plasma to your kidney for filtration through the glomerulus.
And you said it causes what?
Neurotoxicity is right there, ammonia toxicity to the central nervous system. 60% is excreted, 40% is reabsorbed by passive diffusion in the tubules. So even though we do a urea, UUN, urine urea nitrogen, for like 24 hours, and we do measure your blood urea, as we'll learn with creatinine is cleared a little bit differently. So we have to take into consideration that part of it is reabsorbed. So remember way back when I told you how the kidney functions, right? Basically it takes all the trash and puts it on the lawn, and then only brings back what it wants, okay? Well, in this case it reabsorbs 40% of the urea, which is really a waste product, but it does reabsorb it. So elevated urea levels, if it's elevated in the blood, it's called azotemia. Okay, elevation of blood urea is azotemia. A very high plasma urea plus renal failure we call uremia. Okay. Just like with your liver, you have remember we had pre-hepatic, hepatic, and post. Well, same here. Pre-renal, renal, and post-renal. Okay? So pre-renal is reversible. Whatever's causing the problem, just fix it, and your problem will go away. Okay? So with pre-renal, can be decreased your renal blood flow, like congestive heart failure, shock, perhaps the hemorrhage, dehydration. Can be protein intake, a high protein diet. You have a GI bleed, your body's basically going to digest that blood in your GI tract, and you're going to absorb that protein, okay? And so, again, I love the one down here, stress. So I imagine all of you have higher levels, right? Okay, you can also have an elevated blood urea level due to a decrease in excretion. So again, if you're causing more to be formed, okay, then so the renal causes. So your kidneys are not getting rid of it. So acute or chronic renal failure, glomerular nephritis, and tubular necrosis. Okay, so the kidney is something's bad with the kidney, so it's renal. Post-renal would be something with the urinary tract, a stone, a tumor, an infection, enlarged prostate gland for men. Okay, so it's post-renal. Decreased urea levels, advanced liver disease, low protein diet, hemodialysis, normal pregnancy. How come you go potty every 5 minutes? See, so trash is getting thrown away, right? Decreased urea. So in the lab, we have to analyze the blood, and we have to determine what the blood urea nitrogen is. Okay. So normal value is about 6 to 20 milligrams per deciliter. That's your normal, okay? It is an enzymatic reaction, a uricase. The reference method is an isotope, but we don't want to have radioactive material in the laboratory anymore, so even that's still considered the reference method. Nobody does it. We do uricase, and then, again, the reagent is just uricase, and we measure your BUN. And there is interfering substances with anticoagulants, so you have to be careful which anticoagulant tube you use. So like sodium heparin would be okay, but you don't need ammonium heparin. We can do a BUN creatinine ratio. Basically, you take your BUN value and divide it by your creatinine value, because you're going to measure both on the machine. And it will assess your BUN, what's actually causing your BUN to be elevated. So above 20 to 1, so 20 of a BUN to 1 creatinine. If the creatinine is normal, then we're thinking pre-renal. And how do you fix pre-renal again?
It's
Fix-
possible.
Right, you fix the possible. You fix the problem, right. If you have elevated creatinine levels, it could mean post-renal causes. Right? And those are the stones and the prostate and the infection and all that. Okay? 20 to 1, 10 to 1 to 20 to 1 is normal. Again, usually about 12 to 1 to 16 to 1 is normal. Below 10 to 1 could be a low protein intake, tubular necrosis, or liver disease. So those are your reasons for that one. So again, you have to get your BUN value and your creatinine value. So you get your BUN creatinine ratio. And the machine does this already for you. Creatinine. We're going to measure your creatinine. Creatine is, isn't that powder that like weightlifters and stuff do? So I'm not exactly sure why, because it's really kind of a waste product, but I guess it does something, high energy compound for muscles, I guess. We don't really usually measure creatine. We do the creatinine. So again, 0.6 to 1.3 milligrams per deciliter is normal. Let's see, what I want you to know about that. It is secreted into the plasma at a constant rate relative to muscle mass. Okay. And we can check this by doing a 24-hour urine. It is freely filtered by the glomerulus and not reabsorbed. Yes, ma'am.
On the Chem 8 page for the gun, RBUN, do we put the 6 to 20 milligrams per deciliter?
And then is creatinine on there too? So 0.6 to 1.8. Let's see, where was I? Not reabsorbed. So it is a good monitor for your glomerular filtration rate. Your creatinine is a little bit better for that because again, it's not reabsorbed, it's all constant. Abnormal levels of creatinine will accumulate in your blood, okay, with any type of renal dysfunction or a decreased glomerular filtration rate. Elevated serum creatinine, specific for abnormal renal function. It is insensitive to early renal dysfunction. Okay? You basically have to have lost about 50% of your kidney function before your creatinine would be elevated. It's not very sensitive. Okay? Not affected by diet, dehydration, protein, things. Conditions with elevated serum creatinine, again, pre-renal, so decreased renal blood flow, high meat intake, strenuous exercise can cause you to have an elevated creatinine. Renal, loss of your nephrons or kidney disease, it's actually the kidney glomerulonephritis. Post-renal, urinary tract obstruction, infections, tumors, stones. Non-renal can be due to drugs. And at the very bottom it says analytical positive interference, Jaffé method. We're going to go into that in just a second. Conditions with a decreased creatinine. So this means a decrease in your blood. So you have less waste in your blood. Is this a bad thing? You want waste in your blood? a good thing. So again, pregnancy, again, retention of your fluid, increase your glomerular filtration rate. You drink a little bit, go on a little bit, yeah, okay. Decrease with muscle mass, again, wasting diseases, starvation, so it can be a bad thing in those kind of cases. But again, possible, and you don't have to be chronic. Analysis of creatinine is the Jaffe reaction. The Jaffe reaction has been around since 1886, okay? There have been people who have tried to reinvent it, all right? Bolin Wu was one of them in 1909, but it all comes back to the same Jaffe reaction. Because of the interference, the Jaffe reaction is the only one that really works, even though they've tried others, okay? You have creatinine plus picric acid in an alkaline solution gives you alkaline picrate, okay? It is very, very yellow, bright yellow. It stains bright yellow. Okay, so if you noticed over in the corner of there by where they do hematology, if you ever noticed the yellow stain on the floor, yeah, that was because of the, actually what happened was we were changing reagents and we used to have big, huge bottles of reagent in the machine that was there. And somebody changed the reagent and left some at the bottom and didn't bother to dump it down the sink. And a housekeeping person grabbed it and, splashed it all up their leg and all over the floor. And that's why there's a yellow stain on the floor. And that's been a few years ago. Picric acid is explosive, okay? So part of your daily maintenance, whenever you're dealing with a machine that does creatinine, is to check for any kind of crystal buildup on the line of your creatinine, okay? Then if you take those crystals and you were to throw them on the floor, they would be like poppers, okay? So when Sigma, way back in, early 2001, 2, around there, they closed a warehouse in St. Louis, and when they did that, they found a whole bunch of this alkaline, this picrate in whatever, and it actually made the news that they actually had to bring a bomb squad out, and they actually blew it up in some big, huge field. And I remember watching that, and I thought that was really, really cool. So it is explosive, so you have to be careful. So when it says to check that every day, please check that every day, because you don't want that buildup to happen. And it doesn't happen real fast, but every once in a while you'll see just a little bit. But again, if you wipe it down, then you're okay. So again, the kinetic is the Jaffe reaction, and then there are some enzymatic methods, but I want you to know the reference method, which is the Jaffe reaction. And it's alkaline picrate, and it's very yellow. It is, so it will stain. Creatinine clearance, you guys are probably talking about creatinine clearance in your analysis. You probably haven't gotten there yet, have you? No? But when you get there, what you're going to do is you're going to do, so for most creatinine clearance, it's 24-hour urine collection. Okay, so you have a great big huge jar, you collect your urine from morning until the very next morning. And Jean will talk to you all about 24-hour urine collections. And then during that process, so usually we have the patients get their blood drawn when they drop it off, okay? And then you have your urine creatinine and your serum creatinine to put in the calculation. You measure the volume of the urine, put it in there, and then you do a calculation to find out what your creatinine clearance is. So usually with Jean, what she does is she makes you keep your urine for like 4 hours. So she just keeps giving you cups and cups and cups. And then when you fill up all your cups, then you mix them all together in something. I'm not exactly sure how she does that. And then you take a sample. And I don't think I have any creatinine reagents. So I don't know if we'll run anyone. But anyway. So that's the creatinine clearance, but again, you'll do most of that in her class. Talk about doing it and all that good stuff. Uric acid. Uric acid is another waste product and it's a waste product of purine catabolism. Okay, completely filtered. If for some reason the pH of your blood pH is 7, your urates are insoluble, and if your blood plasma becomes saturated, you get urate crystals. You guys haven't done microscopics yet, have you? But urate crystals, so uric acid crystals, you'll have those in your urine. They're very pretty. And then, but what's bad is, yes, you can have them in your urine, but you can also, if it's high in your blood, turns crystals in your blood. You want crystals in your blood? No. And so as it's going through your small little capillaries, they get all clogged up, and then it starts being very, very painful. All right. So for these people, they need to be on a diet that's so overproduction of urate can cause uricemia, hyperuricemia, so uric acid in your blood. So overproduction, again, inborn error of metabolism, one of those inborn errors that you get tested for as a child. And then decreased urine excretion of your urates. And the big one here is gout. It is significant. It is the main one we use to measure for the disease gout. Anybody know anybody has gout? Gout is extremely painful. Usually it affects their toes or their ankles. And again, you get that buildup of those crystals in those joints, and it can be extremely painful. And it's usually after you eat a heavy meal, so like around Thanksgiving when you're eating a little more than you would normally eat. These poor people have a problem. They say that drinking tart cherry juice or eating cherries helps. Does it help? Did the person, does it help?
Yeah, he takes like cherry juice every day.
Tart cherry
It's something in the, the skin of the cherry is what I read once.
Oh,
But yeah, it is recommended.
yeah. So anyway, so that's just kind of a home remedy for that one. But gout, so uric acid, big gout. Okay. Uric acid analysis, serum or plasma. The Caraway method is, it's non-specific. The one I want you to know is the uricase. It's an enzymatic, again, ends in ASE, so it's an enzymatic reaction. And what you end up with your uricase, you get alkaline CO2 in the water, or I'm sorry, H2O2. And again, measures the H2O2 through other reactions. So enzymatic uricase is what you're gonna remember for that one. The normal value for uric acid, this is one of the few chemistry results that have different normals for male and female. Female is lower than male. So just to make math easy, I just rolled them all into one to give you one normal value to remember, okay? Again, males are higher than females, so it's really the low normal for female and the high normal for male. I kind of just rolled them all into one. Let's see. And it just says again at the bottom, the gout is the clinical manifestation of urate crystals deposited in connective tissue. Causes problems. Next slide. Okay, ammonia. The source of ammonia is the deamination of amino acids. All right. And your body converts it to urea in the liver by enzymes to prevent the ammonia buildup, because ammonia in your blood is neurotoxic. It will cause your brain not to function. If you have liver disease, the ammonia is not converted, so again, you would have an increase. And we talked about that when we were talking about liver function. So. Diseases in ammonia, high levels, again, neurotoxic, hepatic failure, acetaminophen overdose will kill your liver. This is not the way you want to die. If you want to kill yourself, do not take acetaminophen, because this is about a 5-day process. Because it's going to start hurting your liver, and your liver is going to slowly die over time, and of course you're going to have a little bit of ammonia in your brain, and you're going to, this is not the way you want to go. We'll actually talk a little bit more about acetaminophen overdose and what the effects of ammonia, all that is, when we do toxicology, talk a little bit more about it. But again, just know that acetaminophen in high levels can cause an increase in ammonia. And I think now they even put warnings on the bottle, don't they, to not take over, I think they do, if I'm not mistaken.
I'm friends with a physician, critical care physician, and he says that's awful because you can bring them back strong enough to tell them that they're gonna die in a few days. There's nothing that they can do to stop it.
Yeah, yeah, it is bad. Yeah. So when we get somebody who's done this in the ER, they put them in ICU, and of course you're just doing ammonia levels, you know, constantly, but you're right, it just gets worse and worse and worse.
I'd heard that ibuprofen will shut down your liver, but is it doing the same thing as acetaminophen?
It's not doing the same thing, but again, all of them will hurt, because again, what's your liver's job, right, is to detoxify. So again, everything in moderation. But acetaminophen is the one that will hurt your liver. So yeah, he's right, it's not the way you want to do it.
So if you are like ingesting toxins, is the first thing to go is your liver?
I'm sorry?
When you are like ingesting toxins or anything that's like very toxic, is your liver the first thing to go?
Usually, because remember, that's its job.
Yeah.
It's trying to detoxify. Now, you know, but sometimes your liver can't clear it all, and if it's something that would cause toxicity to your brain or to your lungs, enough of it might get through your liver to actually affect one of those two if they're more sensitive to whatever it is that you've done.
Why do doctors tell people to drink 2 glasses of red wine or 2 beers to help clear out the liver? Isn't that alcohol is just another poison?
I've never heard that. What needs to be refrigerated? Oh, okay. Yeah, so I don't know. The only thing I know about drinking wine or a little bit of alcohol is more for your lipids. So I don't know anything about it cleaning your liver.
Well, the 2 people that I know have been told that I've had issues with their lipids, so it might be.
But you can have a fatty liver. You can have lipid deposits in your liver. So I don't
Would that
know.
help?
It's more of that cleaning out process. I don't know. I've never really heard that. I've always heard that wine or a little bit of alcohol would reduce your cholesterol. So do what?
Also your stress level.
Your stress. Yeah. Last time I had a wine cooler, I couldn't walk for 5 hours, so I don't do it anymore. Rye syndrome is a condition, again, with children, if they take aspirin, okay, again, they can have an increase of ammonia. And it can cause problems with children because of that too. So Rye syndrome is another, and we'll talk a little bit more about that, again, the toxicology. Your aspirin. Okay. Testing of ammonia in the laboratory. You have to have good specimen handling. Quick and cold, think quick and cold with ammonia, okay? So if you're gonna draw the specimen, you have to put it on ice, and it has to go down to the lab, and we have to run it. We used to have a refrigerated centrifuge, but now we have a stat centrifuge that spins so quickly, it's not worth putting it in the refrigerated one. We actually got rid of the refrigerated one. And you need to test it within 20 minutes. So what we actually have in our lab is a little ice block with a hole in it, so you can draw blood and then just put the tube in this little ice block. A lot of times nurses, if they draw them on the floor, will put them in a cup with some ice. And the only bad thing there is that then the label gets wet, and then you try to put it on your machine, and the label's wet, and it won't read the barcode. And so then you gotta print a whole new one. So if you're the one drawing the blood, or if you know of anybody that is going to draw the blood, if they can drop the blood into a glove, and then put the glove into like a cup of ice or something, it'll keep the tube cold, but then the tube won't get wet, and then the label won't get all icky. Have you seen people dumping ice from those into my eye wash?
Yes.
Yes, and you need to tell them, Barb said, do not do that.
Okay.
I mean, think about it. They're dumping biohazard ice, right, into my eye wash. I didn't check my eye wash the other day, and there was ice in it.
Yeah, they do it all the time.
Yeah, I know. I'm gonna have to put a big sign. Well, really, do you want to wash your eyes? If you get something in your eyes in my eye wash that people have been dumping icky ice in? Makes me mad. I do. Quick and cold, okay. So if you get an ammonia level and you get it and it's warm, are you gonna run it on the machine? You get a tube of blood for ammonia, are you gonna run it on the machine? No. And if it's already, 2 hours old, are you gonna bother to run it? No, quick and cold. So usually when we get an ammonia, well now, back in the day, we didn't get them all the time. And so usually when one would get ordered, they'd let us know, so we'd have our controls run, so that by the time it came down, we'd go ahead and run the specimen. But now we're getting more and more and more of them. So doing ammonia controls is now just part of our daily run. So we just do it automatically now.
And this is a blood draw, right?
Yes, blood draw. Just a vena puncher, it's not arterial or anything else. Yes.
Will the ammonia levels increase faster than the acetaminophen levels?
No. You're talking about when they ingest it? No. Mm-mm. The acetaminophen level will be high, and then the ammonia will kick in. Mm-hmm. Yes, ma'am?
If you were using an ammonia-based cleaner and you inhaled it too much, would your lungs be affected first, like more than your liver? Like would it shut down your lungs?
Exactly. And again, if you
Before
inhale
it
it, then
kills
of
you
course
the
it's
other way.
gonna go right to your head too. Yeah. So, not good.